This will be on cervical disc disease, and we will try to discuss arthroplasty versus fusion. And the moderators will be Sandeep, Vaishya, and Sérgio, Salvador. I give the words to them to moderate the session.
Yeah. Hello, everybody. So now we will start the session on cervical arthroplasty versus fusion. Is Oscar here? Oscar is the first speaker. Yeah, can you hear me?
Hello. Hi.
Oscar is here.
Yes.
So Oscar, you can start now.
Please let me share my screen.
Yeah.
We see your screen.
Can you see my screen?
Yes.
All right. Thank you. So thank you so much for the invitation, WFNS. My lecture is on cervical arthroplasty, indications and patient selection. I would like to greet our colleagues, Nikolai and Joachim, and also the moderators. I have no disclosures for this presentation. And basically, I should start my talk about what are my contraindications, and this is what we publish on a book chapter for cervical arthroplasty. And this is mainly related with significant facet joint degeneration, important modic changes at the disc level, of course, large osteophytes, diffuse OPLL, ankylosis, deformity more than 15 degrees, and a lot of motion or motion restriction due to facet fusion. And of course, osteoporosis, osteopenia, infection, allergy. So it's really important patient selection and respect all these contraindications. Poor candidates for arthroplasty.
Oscar, we don't see your slides.
You don't see?
We don't see your slides. We see your screen only.
Oh, I'm seeing my slides myself here. Oh my gosh. What now?
No.
No.
Let me restart. Now?
Yes. Now we can see.
I'm sorry. Okay. So I said this word. These are my contraindications for cervical arthroplasty, and this was published on a book chapter on cervical spondylotic myelopathy. And as you see here, most of the contraindications are related with the status of the facet joint. If you have degeneration, if you have significant arthropathy, or if you have diffuse OPLL, instability, significant kyphotic deformity, osteoporosis, osteopenia, these are important contraindications. In all other situations, I'll always try to do a cervical arthroplasty when I have a cervical disc disease. It's important to do patient selection and respect contraindications. And as in every surgery, poor candidates for arthroplasty are more prone to complications. And this is especially true if you look at the multi-level disc disease. You have to consider at each individual level and scrutinize all the levels for the identification of these contraindications. It's important why to adhere to a cervical arthroplasty, because you can preserve range of motion and quality of motion. You see that in degenerative disc disease, significant motion occurs in the subaxial spine where the disc disease is more prevalent. And for your daily life, you need quite a lot of motion in your neck, tying the shoes, backing up a car, washing hair in the shower, crossing the street. And if you go for the option of fusion, you will lose these capacities. And I think fusion, especially multi-level, has a negative impact on the cervical spine global function. People are not so happy as this lady and it's fully tolerated when you assess quality of life, especially in young patients with higher life expectancy. Fusion originates motion loss and stiffness, and you look at the biomechanical studies, arthroplasty are similar to intact segment. And we have very good data now showing motion preservation. This is a paper with a 10 years outcome, long-term preservation of range of motion despite the occurrence of HO. This is one study I did with my PhD student, 31 patients. We look at the range of motion, but also the location of the center of rotation using the SpineView software. And we found that there was a very good reproduction of the range of motion along the cervical spine as expected in asymptomatic adults. This is all what I call an adaptive technology. And the center of rotation location became to normal 1 year after the operation. So you need to have quite extended follow-up to see the advantages of arthroplasty. It allows me also sagittal balance correction and preservation. You know it's important. That's the why you stop myelopathy progression is by doing a good correction of imbalances with your surgery. And in 35 patients, we promoted a good index level alignment and also global alignment. And the increase in global lordosis was derived from an increase of index level lordosis. And this has been supported by this meta-analysis. Of course, if you departure from a low pre-opti-1 slope, it will be easier to restore sagittal alignment in kyphotic patients. And also this meta-analysis shows that on adjacent levels, you have a protective effect in reconstruction of sagittal balance. We have demonstrated that in our paper published in 2020 with multi-level patients with a quite interesting follow-up, as you can see here. And there was a good sagittal balance in operated level that was significant and in global level. And doesn't matter if you do 2 or versus 3 and 4 level patients. The difference, it's not relevant. You have the same performance of the disc prosthesis. This for me is the most compelling argument for using arthroplasty instead of fusion, what I call protection of compensatory mechanisms while you are aging. When we age, this is what happens. Your SVA, cervical SVA increases, and there is an hyperextension at C0, C1, C2, and the lower compensatory flexion. If you do a fusion, you lose this capacity. Just to show here some examples, 45 years old female, and over the years, 5 years follow-up, there was an increase, there was an increase in cervical SVA, an increase in lordosis C0, C2, and a decreases in lordosis from C2, C7. This is a case of hyperostosis, idiopathic, that we dare to do a cervical arthroplasty. And these are also 7 years follow-up, a good preservation of the range of motion. And you see here over the time, loss of segmental lordosis, but the prosthesis was still mobile. Another case here, range of motion coupled with positive sagittal balance with 8 years follow-up. What about the clinical outcomes? Nikolai will talk us about this. I'm really being very brief, but this was the most scrutinized entity in spine surgery, high quality data, as you see here, RCTs across different type of devices, long-term outcomes, and none of them were inferior. And I have to tell you that none of these studies were done with third generation devices. And third generation devices with 6 degrees of freedom, the likelihood of having a range of motion in physiological range of motion is higher when you apply this kind of implants. So highest proportion of implant segments with physiological motion compared to cohorts. Another, also the center of rotation location with this device is better. The low displacement curves are also close to normal, to the intact level with these devices. So I think with all these new generation devices that we have, with near normal cervical kinematics will for sure have improved outcomes. Cost effectiveness and reimbursement introduces a noise. International experts, they acknowledge that the cost of the device played a big role in whether of offering it or not. Here in my country, I don't have a bias because I get the same money if I do an ACDF on an arthroplasty, and the cost of implants is not that different. If you look at the real world data from National Insurance Database in the US, those are studies outside the ID studies. It's a retrospective study. It's 12% cheaper, less reoperations, increased return to work. So it looks a more effective surgery during the lifetime of a patient. And this is because you have less index level second surgeries. Long-term follow-up, level 1 evidence, this is what you get doing arthroplasty and what you get doing ACDF. So coming to the topic, to my topic, I don't think you should apply arthroplasty only as a standard indication in single level disease, in a radiculopathy caused by a disc herniation or myelopathy with a soft disc preserved height. This is where we started. But if you look at multi-level diseases, if you have multi-level fusion, it just exacerbates the negative biomechanic effect of single level fusion. You have higher increase in cervical stiffness. So in a way, it will be more clinically meaningful to offer motion preservation technique in multi-level disease patients than one-level patients. And we have studies here. It's a study comparing two-level versus one-level arthroplasty, and the effectiveness, clinical effectiveness compared to ACDF is more apparent when you increase from one level to two levels. And this is what the study I showed before clearly shows. 5 years follow-up, better NDI, short form, 12 physical component, better overall satisfaction, less reoperations. Long-term follow-up, the more you follow up the patients, 10-year follow-up, the more you will see a difference between arthroplasty and ACDF. From no major difference in clinical and radiological outcomes when you plot single level versus multi-level. This is a level 2 evidence study. In our study, we have shown also the same. This is a good range of motion, global index level, and this is in strike contrast with fusion. If I see when I operate a patient that it's symptomatic from one level, and on adjacent level, there is already some sort of degeneration, I think this is a good indication at the index level to do an arthroplasty instead of a fusion to protect that degenerated level that it's not yet symptomatic, is not causing radiculopathy. Because doing an arthroplasty, you don't increase the range of motion of adjacent levels as you see on fusion. There is a phenomenon also with fusion that you increase intradiscal pressure of the adjacent levels. And as you age, your SVA changes. Also, this intradiscal pressure is in direct correlation with the change on SVA after you perform a fusion. So incidence of ACDF is 3% a year, 25% within 10 years. In this study, long-term outcome, you don't see hypermobility in adjacent segments with arthroplasty, superior to ACDF. And the more you follow up the patients, the less, the more second surgeries you see in adjacent level in fusion versus arthroplasty. As you can see here, this is really the same study, 2 years, no different. Level of operation at the adjacent level, but when they look at the same data 7 years later, there was much less operations with CDA compared with fusion. This is one of our cases and an ACDF done in 2014, adjacent segment disease. You see this disc was completely collapsed during the surgery. We were able to reformat the disc and insert an arthroplasty. And this is the result on at 68 months follow-up. What about index level kyphosis? There is a beneficial effect on sagittal balance. I showed it before. So why kyphosis? It's still index level kyphosis is still a contraindication for arthroplasty. And this is basically based on the KIM study that showed that only 13% of pre-op kyphotic index levels became lordotic. It's much more easier to reconstruct global lordosis from global kyphosis than at index level. We look at the 23 patients of ours with 25 kyphotic levels, and there was a significant increase in segmental lordosis at every kyphotic level. And this is in strike contrast with the 13% of the KIM study. And there was also an increase not significant in the global C2 to C7 angle. This is one case, minus 13.2 degree on this case here. It was flexible, but not fully reducible kyphosis, as you can see here. And there was a dramatic increase in lordosis with the implant from almost 18.5 degrees of increase, with a gain in range of motion and a good sagittal alignment and a good location of the center of rotation of the disc. Sometimes the prosthesis itself cannot do all the job, and you have to reformat with your surgical technique, do some sort of osteotomy to reformat the C5 vertebra, like here, and insert this prosthesis and be able to reproduce from day one this very nice lordotic alignment. So in my hands, reducible segmental kyphosis is not a contraindication for arthroplasty. What about slit disc disease? This is this kind of patients, young patients with collapsed discs, we see more and more in our practice. 29 years old female with a myeloradiculopathy, 3-level compressive disc disease, minimal facet joint degeneration. And this is what we got. Disc height 4.5 came from 2.6 to 6.6 millimeters. And with a good sagittal alignment, as you see here, better sagittal alignment and a good range of motion. So I think in those patients, even though they have collapsed discs, the multi-level arthroplasty may represent a window of opportunity to treat earlier patients with mild, moderate forms of myelopathy. And you don't compromise decompression here by doing an arthroplasty. Another case, 49 years old female, high-ranking official, administrative official in Portugal, and look, the dramatic increase in disc height with very good results. This is how I assess during my surgery. I don't use pin retractors. I do all my decompression, and then at the end, I do this leverage maneuver with the suction. And if I see that there is a good motion, I insert a disc prosthesis instead of a fusion. We look at our patients, and we identified 28 patients. This was done maybe 3 years ago. We have more patients. We are updating the data. 48 years old, mean age, 39 pathological levels, and see the nice increase in disc height, in disc angulation, and on the range of motion. So in collapsed discs, you can do a very nice job if you use this kind of compressible disc prosthesis. And it was interesting to see that more collapsed discs showed a higher increase in disc height and also a higher range of motion. And this is due to the fact that the facet joints were preserved. If you are facing ACDF pseudoarthrosis, and I'm sure Joachim will tell you about this, and it can reach 10% or multi-levels, you can go 1/3 of the patients, you're facing this complication. An arthroplasty is a good option here. 2016, 2-level ACDF done somewhere else, 2017, and goes, and you have even some ossification here behind the fusion, which is something not only happens in arthroplasty. And it came to me, I did a 3-level hybrid surgery. So this was in 2018, 23, and I replaced one of the cages where pseudoarthrosis was seen by a disc prosthesis. The other one was not possible. So these are my expanded indications, and these are some of the papers that we published, Mehmet book, also Neurosurgical Clinics of North America, and it's a nice paper, nice tips and tricks that you can see there. So in conclusion, arthroplasty mitigates negative biomechanic effects of ACDF. Long-term follow-up showed superior clinical outcomes, less reoperations at the index of adjacent level, greater cost utility. It promotes positive sagittal balance and capacity even to reverse kyphosis. The positive results are amplified if you do multi-levels compared to single level. It's a reliable technique in unconventional cases like collapsed disc kyphotic levels, and it's a chance to operate younger patients as you preserve compensatory mechanisms as opposed to fusion surgery. Thank you.
Thank you, Oscar, for an excellent talk. And there is always a discussion about there are a lot of publications about the contraindications in for cervical disc arthroplasty, and I personally feel that many of them are being written by people who actually don't do them because we are expanding our indications, and we see that these patients do pretty well and they are very happy. Sometimes you can't just express it in percentages and p-values, but the patient satisfaction is pretty good in these cases. So I congratulate you for presenting this data.
I think the more you follow up the patients, the longer the result will show up.
Yeah. Sérgio, do you want to add anything?
No. We
Sérgio,
can
nice to see you.
Nice to see you, Dr. Alves.
So I think we can take all the questions at the end. Let us go to the next talk.